Okay, welcome back. Let's talk a little bit about bag valve mask technique. So the actual technique we'll demonstrate in class and we'll get some hands-on practice, but I want to talk about the theory of bag valve mask. All right, so as we mentioned with airway management, every single time we approach a patient when we're going to help or we're going to take over breathing, that is their ventilation and oxygenation, we have to predict whether or not we're going to be successful before we even start. It's important for us to look at the patient and to apply certain rules that we'll teach here and be able to decide whether or not our plan A is going to work. And if it's not, what should our secondary or tertiary plan be? So even for bag valve mask technique, there are three things that we want to do. We want to define what difficulty is, of course. We want to predict difficulty. In other words, are we going to have difficulty bagging this patient? And then we're going to see how we can improve success rates of bag valve mask technique by predicting difficulty. So let's take a look at what we mean by difficulty. We talk about bag valve difficulty as being the inability to maintain a greater than 90% SpO2 while we're using supplemental oxygen. So that is, if we have a bag valve mask and we're making the proper interface with the patient, are we able to maintain SpO2 greater than 90%? So that's going to be kind of an important thing, because at the end of the day, what we need to be able to do is to oxygenate the patient. That's the point of ventilating them in the first place. All right, so how often does this occur? Difficulty occurs in about 5% of the patients. So 5 out of every 100 patients that you end up having to bag, you're going to have difficulty. You're going to be completely unable to do so, or you're going to be unable to maintain an SpO2 that's within an acceptable range. So there's this mnemonic, and the mnemonic is MOANS, and MOANS is something that Walls and Murphy developed. If you are so inclined and you want to learn more about emergency airway management, buy their book, The Manual of Emergency Airway Management. They're in their 4th edition now. It's an absolutely phenomenal book. It's pretty much the Bible of airway management. So MOANS is a mnemonic that we can utilize to assess our patient and to predict difficulty in bag valve mask. So what does MOANS stand for? All right, so the mnemonic MOANS starts M for mask seal. So I think the picture says everything that we need to say here. There are going to be patients that have a tremendous amount of hair on their face, or there may be something else that's going to interfere with our ability to make a good seal between the mask and between the patient's face. So mask seal is the M in MOANS. This is obviously going to provide some difficulty for us. All right, the next thing is O. O stands for obesity. Again, the morbidly obese patient is always going to challenge us when it comes time to either assisting or taking over ventilations. The issue here is that we have to overcome tremendous airway pressures. We have to overcome all of the weight that's being pushed up onto the diaphragm, and then increasing thoracic pressure, the intrathoracic pressure, as we mentioned in the mechanics of breathing slide set. The A stands for age. Those that are of advanced age tend to give us a little bit more difficulty, whether it's the shape of their face. That's going to present some challenges for us. The N stands for no teeth, or the edentulous patient. Patients that don't have teeth also fail to have the same structure behind their face, skin, and their overall face shape. And that's going to change our interface between the mask and, of course, the patient's face. So we may have more leakage around certain areas near the zygomatic bones, or around the corners of the lips there. We may end up having some mask seal difficulties. And then patients that have difficulty sometimes with no teeth, you may have some difficulty sealing at the bottom there where the chin itself is. So we're going to talk about some techniques that we can use to overcome those things. And then last but not least, the S stands for sleep apnea, or stiff lungs, or a stiff chest. So patients that are known to have sleep apnea tend to have more obstruction when we go to bag them. So this is going to really tell us about the need for good adjunct use and good selection, correct sizing, and so on. Stiff lungs refers to COPDers like emphysema, or also the asthmatics. Their lungs are stiff, and therefore we're going to have to overcome higher airway pressures than we would in a normal patient. And then last but not least, the stiff chest patient. Again, this could be a COPDer. So the MOANS mnemonic is not it's not a solution. It's something that it's a tool that allows us to predict airway difficulty. And so if you can predict that you're going to have difficulty with the bag valve mask technique, you can actually put into place some things prior to even starting bag valve technique that will allow you to be successful. So one of the things that we're going to talk about in class is how to correctly size the mask, because masks are not one size fits all, and hopefully you already know that. We're also going to mention the two-person technique and get an opportunity to practice with that. It's going to be important for you to realize that if you're actually doing good bag valve technique, it's very difficult to do by yourself, A, and B, it becomes tiring very quickly. So within a couple minutes, it's very difficult to hold a good seal between the mask and the patient's face. So 2 people is always better than 1 when it comes to bag valve technique. 1 person is going to exclusively be holding the mask and ensuring that interface is solid, and 1 person is going to be squeezing the bag. We're also going to talk about the use of dual nasal trumpets or nasal airways. We'll show that in class. Walls and Murphy, again, they support that. In fact, they encourage the use. There is scientific evidence, there is data, there's research to support that. We'll talk about oral airway when we get to the actual presentations in class and the demonstrations in class. I'm going to tell you that the oral airway is something I don't really like to use initially, especially if I may move into intubation. And the reason for that is because if I put it in incorrectly or if I don't have the right size, I'm going to cause more obstruction than I am help. The other thing is when I go to intubate, now I have to remove the oral airway. It's just one more step for me to do, and I can achieve equal, if not better, airway management with nasal trumpets. But we'll talk more about that in class. Reverse Trendelenburg talks about placing the patient's head higher than their feet. So the importance of that is to, again, alleviate pressure off of the diaphragm and to minimize the airway pressure just by positioning of the patient. And we talked about that in the patient positioning slide set. This is always going to be an important thing. Remember that patient positioning is of critical importance to your success and your ability to efficiently ventilate and then, of course, oxygenate the patient. So remember in MOANS, we talked about mask seal issues. That was the M. And one of the techniques that you can use here is to take a tegaderm or several tegaderms and just put it over top of the bearded area so that you can actually make a solid seal between the mask and the tegaderm. So that's one little trick, and it works really, really well. The other thing that you can do is you can take KY jelly and you can just goop KY jelly onto the bearded area where the mask is going to touch, and that will also provide you with a great seal. Remember that you may never, ever, ever use a petroleum-based product where there's going to be oxygen flowing. So don't forget that, or you'll end up with you could end up with a fire or a flash explosion. It's important for you to remember petroleum products and oxygen, pure oxygen, should never mix. So we're talking about KY jelly here, a water-based lubricant, nothing with petroleum in it. All right, so for the edentulous patient, if they have dentures in, sometimes the best solution is not to remove the dentures, but to leave them in and allow them to provide support to the soft tissue so that you can achieve a better mask seal. All right, and then I'll also show you when we get to class, when we demonstrate these different techniques, we'll talk about taking some gauze and packing gauze in between the cheeks and the teeth to try to maximize the surface area and the structure that exists so that we can get a better mask seal with the face. So we'll demonstrate all these techniques in class. I just wanted to introduce them to you here. All right, so again, you have this patient. If this patient is hypoventilating or is apneic and you have to do something about that, again, I hope that now using the MOANS mnemonic, you can kind of look at this and you say, wow, I'm probably going to have some mask seal issues. I'm also going to have some difficulty because this patient is morbidly obese, and that's going to present some challenges with overcoming airway pressure. So patient positioning is going to be really, really, really important here. I don't know how old this gentleman is, but remember that advanced age is going to cause some problems. This gentleman looks like he still has teeth, so the N there doesn't apply. And then last but not least, I'm going to go out on a limb and just say this patient probably has sleep apnea. If he's not on a BiPAP machine, he probably should be at night. And remember that morbidly obese patients tend to also have sleep apnea. So just be considerate of those things, and then know what you're getting yourself into. So even before you start bagging this patient, maybe it's important for you to recognize those things and to approach the patient a little bit differently than you would your average person, whatever that is. And then what are you going to do if that fails? In other words, if you attempt to bag this patient and you're unable to maintain good oxygenation, or you're unable to ventilate him, how are you then going to approach that patient to be more successful? Because we need to be able to oxygenate the patient. All right, so take a look at this graph for just a moment. And this graph is kind of illustrates the importance of preoxygenation, because if we take a patient and we preoxygenate them, it gives us a tremendous amount of flexibility, a tremendous amount of time. So if we start at the 100% mark, or right around the 100% mark, we have around 8 minutes. At the 8-minute mark is when we cross the 90% SaO2. So this really gives us a tremendous amount of time. In the otherwise healthy patient, if you go to the operating room and we oxygenate you to the 98 or 100% mark, just a couple vital capacity breaths of oxygen, and you achieve an SpO2 of 98 or 100%, now we can sedate you and paralyze you, and you can do absolutely no movement, no ventilation of air whatsoever, and you can still maintain SaO2 levels of approximately 90% for about 8 minutes. And then you see after that, it really, really drops off very quickly. And that's the case for all the other patients as well. So the take-home message from this chart is this. If you start oxygenating the patient before you even mess with intubation, before you do any aggressive and invasive airway management, if we're able to pre-oxygenate the patient with something like 5 to 8 vital capacity breaths, where the patient takes a big, deep breath in of 100% oxygen or close to it, this gives us a tremendous leeway. This gives us minutes of time to overcome any difficulties that we anticipated having anyway. It just gives us a couple extra minutes to put into practice and put into play our backup plan. As you see, as we continue to move towards the left here, children tend to desaturate pretty quickly, so we're at about the 3-minute mark. We cross the 90% barrier. And again, the morbidly obese, this is not even an ill patient, but here we're at 2.5 minutes. We desaturate pretty quickly. So just be aware of those things. Those are important things. All right, we're going to talk about bag valve mask equipment when we get to class. I want you to be familiar with the absolute basics. I think everybody knows about bag valve, the mask itself, and the oral airway and the nasal airway adjunct. So we'll talk more about those when we get to the demonstrations. All right, so that's it for now. That's the overview of bag valve mask technique. And remember, we want to be able to predict airway difficulty and to predict difficulty in the technique that we're preparing to employ. All right, that's it for now.